So just a brief reminder that this ECHO program was developed in coordination with the University of Washington, ITEC, as well as the University of New Mexico School of Medicine. And I have no disclosures to discuss at this point. So today's learning objectives will be to summarize the global and local burden of COVID-19 morbidity and mortality, to discuss risk factors for severe outcomes in COVID-19 disease, and to discuss the potential impact of HIV infection on COVID-19 vaccine success. So we're going to have a conversation first. We're going to talk about the global and regional burden of COVID-19 first. Then we're going to talk about the susceptibility to disease of persons living with HIV to COVID-19, predictors of COVID-19 outcome among persons living with HIV, and some of the issues surrounding vaccine development and effectiveness. And then we'll end with a brief summary. So this slide is sort of our new watershed moment. On the 5th of January 2020, when WHO China office essentially reported there's this new unknown code that was happening in the city of Wuhan in the Hubei province, and everything sort of came from there. And the virus was identified as the SARS-CoV-2, and there were lockdowns and universal masking and hand sanitizing and new normal, and our world essentially changed on an instant. And what that caused was this shock to the system, both sociologically, epidemiologically, medically, all sorts of ramifications with respect to how we manage ourselves and how we manage this new illness. One of the unfortunate consequences as well of this new viral pandemic was that there was a significant disruption with respect to care and services delivered to persons living with HIV. There's also a disruption with respect to supply lines of antiretroviral medications, so there were risks for stockouts and those sort of severe issues, and there was the potential for losing a lot of the gains that were hard-won in terms of prevention and treatment. So let's first have a conversation about the global distribution of COVID-19. So this was taken yesterday afternoon, and the areas in darker blue indicate areas where there are more than 100,000 deaths. So in our own neighborhood, the United States of America hits one of those grim milestones, over 25 million cases, over 400,000 deaths. On the other side of the Atlantic, the United Kingdom at 3.7 million, and they crossed 100,000 deaths. And our neighbor to the south, Brazil, over 8.8 million and 200,000 plus deaths. So we were surrounded by a lot of pain and suffering as a result of this pandemic. So if we talk about region by region, the region of the Americas is the most heavily affected, with over 43, maybe 44 million cases. Most of those cases come from the United States, at over 25 million. Next most affected is the European region, 33 million, and we know all the countries, including the UK, that's entering second and third lockdowns now. Southeast Asia, where some of the earliest cases were seen, have enjoyed a lot more success. And some of that, and in addition, Eastern Mediterranean and Africa, where there are a much smaller burden of disease, is born from the fact that they would have had more experience dealing with viral pandemics, with first SARS, then MERS, and in African subcontinent, Ebola and HIV in and of itself. They would have built up the infrastructure with respect to contact tracing and isolation and that sort of thing to get control of the pandemic early. So in terms of what the situation is in Trinidad and Tobago, so we're just shy of 7,500 cases. Our first cases would have been in late March, early April. We suffered a spike between September and October, and we're sort of trending down now. So we're just about 134 deaths, and thankfully we haven't had a death in the last couple of days. So let's talk about the susceptibility to disease with respect to HIV and COVID-19, about the factors that underlie that susceptibility. So when we think about susceptibility, it's not only biological susceptibility. We have to think about how the organism, the host, and the environment interact to render a person susceptible to any disease. So we think about first the host factors, the age of the person, the infectiousness of the disease, and how infectious the vector is. In this case, we another person. Severity of the illness, we know that persons who have more severe COVID-19 tend to have higher COVID-19 viral loads, tend to shed more COVID-19, and tend to transmit more. And as well, host defense factors. We would think about CD4 count and viral load, but the precise mechanism that underpin whether or not someone living with HIV with a low CD4 count is proven to be, even though theoretically it makes sense, to have higher rates of acquisition of HIV has not yet been proved. Multiple studies have not yet been able to demonstrate necessarily higher rates of COVID-19 acquisition among persons living with HIV stratified by things like CD4 count and viral load that is greater than the general population. Some part of that just has to do with the fact that a lot of the early studies were relatively small. So if we're trying to tease out a relatively uncommon event among a relatively uncommon part of the population, parts of the world where HIV is not a generalized epidemic and less than 1% of the population is infected, you need a fairly large study to demonstrate significant differences. But other than the host factors, we also have to consider environmental factors. So for example, with COVID-19, the more we learned, the more we understood it's at least some significant part of transmission occurs due to airborne transmission and aerosol as well as droplets. So if you're in an indoor versus outdoor environment, if the air is poorly ventilated, if you think about some of the long-term care facilities where it's the same population of persons breathing in the same air, that could contribute to increased chances of someone acquiring COVID-19. As well as contact patterns, so proximity to the index case. If it's the person who is infected with COVID-19 sleeps in the same bed with you, eats on the same table with you, you share the same space, whether that person has symptoms or not, because we understand that there is some amount of asymptomatic viral shedding, the chances are that you may likely, after prolonged exposure, develop COVID-19 as well. And finally, socioeconomic factors. So the fact that we are all here having this conversation at distance puts us in a fairly privileged situation. There are many, many millions and billions of people around the world who cannot do teleconferencing, they cannot do social distancing, who cannot do the kind of social isolation and quarantining that might be necessary in order to prevent control of disease. And those are driven by things like poverty, job insecurity. If you work in a crowded work environment and you're earning less than $1 a day, and if you don't come to work, they'll find somebody else to take your job. If there's an outbreak, you might not necessarily feel empowered to not come to work because they didn't give you a mask, or they're not doing social distancing, or don't have hand sanitizer that morning. So this is a summary of some of these studies that would have been done with persons who are with different cohorts of HIV and COVID-19 co-infection. The studies highlighted in to the right of the screen, don't beat me up for the colors, essentially in summary state that the rates of COVID-19 acquisition among multiple different cohorts did not appear to be significantly different than general population. So in some studies, most of them actually was less than 1%, so 0.68%, 0.8%, let's see, 0.92% was the highest one, which was still fairly low and not necessarily indicative of increased rates of COVID-19 acquisition among persons living with HIV. The problem is it may just have been that those studies, as I said, really were just too small to be able to identify a difference. And in terms of some of the studies to the right that were highlighted in green and yellow, it just highlighted that in terms of some of the mortality data that some of the early studies threw out, they were wildly inconsistent. So one of the studies that was done in a series of just about 9 patients, the mortality rate was 7 out of 9, or 7.8%. And another one was 51 out of 28 subjects through, so 1.8%. And in a third study, so 2 out of 47, so just less than 2% mortality. So the variability was just too wide, and I think a large part of that was study design and sample size. So this is just, again, to re-emphasize, when we think about interpreting any study with respect to HIV and COVID-19, we have to think about those factors that confound some of the medical issues we think about with respect to susceptibility and risk. So, as I mentioned before, lower socioeconomic status, job insecurity, inability to social distance, crowding of the household in some cultures where you have multi-generational households, so granny, mommy, daddy, kids, grandkids all in one house, and how that would affect risk of someone younger, possibly asymptomatic disease, coming back home, transmitting infection to one of the older persons in the household, who would then have a severe outcome. Adverse living or working conditions, chronic stress, and the other social determinants of health, so sanitation. We mentioned about household income. We mentioned about things like abuse within the house. You know, are you able to leave the home? And in the case of significant stress, severe psychosocial stress, what impact would that have on your immune system? And of course, pre-existing health conditions that we will come to shortly. Right. So, in terms of some of the predictors of disease outcome with HIV and COVID-19, so we learned this very early on, that the mortality rate with respect to COVID-19 was significantly dependent on age, whereby if you were under 40, the rates of case fatality were less than 1%, whereby if you're over 80 in some cohorts, it's 20-odd%, 15%, which is significant mortality. So the CDC put out a list of some of the, other than age, some of the other underlying comorbidities that tend to cause increased risk of severe outcomes with COVID-19. So things like cancer, chronic kidney disease, COPD, which is emphysema or chronic bronchitis, Down syndrome, heart conditions such as heart failure, immunocompromised states from, for example, the immune system from solid organ transplant, where you're on immunosuppressive medications, especially those that tend to deplete your B cell compartment, obesity or severe obesity, pregnancy, sickle cell disease, and smoking, and type 2 diabetes. In addition to those, there were some conditions that were considered to be likely contributors to severe outcomes, but the body of data to demonstrate that increased risk was perhaps not yet there. So things like moderate to severe asthma, strokes, cystic fibrosis, which is a chronic lung disease, hypertension, immunocompromised data. When we highlight HIV, and we'll come to the body of evidence that is starting to grow that tends to support the likelihood that, in fact, HIV is one of those conditions that contributes to a greater risk of a severe outcome. Use of immunosuppressive medications, neurologic conditions such as dementia, liver disease, overweight as opposed to obesity, pulmonary fibrosis, and thalassemia and type 1 diabetes. So some of the, as I mentioned before, some of the early studies included relatively small numbers of patients and gave conflicting, inconsistent results that did not address confounding variables. So for example, they might have reported on a case series and had CD4s and viral loads, but didn't document whether or not they were comorbid conditions, didn't document the underlying socioeconomic conditions that affected the persons in that case series, didn't document whether there was a waiting maybe we'll talk about a couple of those studies shortly. So there was one systematic review in 2020 that did report no evidence of worse outcomes with suppressed HIV and normal CD4 counts, but again was sad with respect to some of the comorbidities. And some of the later studies that we will now discuss, and some of the observational cohorts suggested increased risk of severe disease and worse outcomes among persons living with HIV. So just to pause here to mention another additional factor we need to consider. So we know that the lifespan of persons living with HIV has been increasing with time as persons and more persons are on suppressive ART, so that the difference in life expectancy between somebody who is HIV positive and HIV negative, let's say in the early 2000s, could have been was over 20 years, whereas the difference in life expectancy, if you started ART basically in the last 5 or 6 years, was down to about 9 years, and if you started with a CD4 count above 500, it was down to less than 6. That being said, the comorbid free life expectancy, in other words, how long after initial diagnosis could you be expected to have a healthy lifespan? There's still that persistent gap. So you see this, in other words, person with HIV was still getting comorbidities, and by comorbidities you mean things like chronic liver disease, kidney disease, chronic lung disease, diabetes, cancer, or cardiovascular disease 10 years to 15 years earlier than the HIV negative counterparts. And that feeds in to the considerations we have to make with respect to comorbidities and how those comorbidities affect COVID-19 risk. Because we are cognizant, and the evidence is showing that comorbidities increase COVID-19 risk, but there's the risk of a comorbidity in and of itself is inextricably linked to that person's HIV status. So it becomes harder and harder to tease apart how much of the excess risk is related to the comorbidity and how much of the excess risk is related to HIV. So this was a study that was done in the Western Cape, South Africa, in a population cohort study of more than 3 million persons accessing public health sector health facilities, of whom about 16% of persons living with HIV. And this essentially was persons who were in care for at least within the last 3 years, what the hazard ratio was for dying of COVID-19 based on a lot of different parameters. So for example, age, sex, weight, diabetes status, HIV status, hypertension, chronic kidney disease, and so forth. And what essentially it showed was that if you adjust for age, sex, and comorbidities, location as a proxy for socioeconomic deprivation, the hazard ratio for death due to COVID-19 was 2.14 times for increased risk of persons living with HIV. Less than, for example, tuberculosis, but comparable, for example, chronic kidney disease. Notice that with respect to age, that the risk ramps up very rapidly after the age of 40 to 49. So by the time hitting 60, 69, over 70, it's 20 odd times increased risk of mortality as a result of COVID-19 exposure or COVID-19 infection. What this study was actually able to demonstrate is that any person with HIV with a viral load over 1,000 copies in the last 15 months, or CD4 count less than 200 in the last 18 months, had over 3.3 times, nearly 3.4 times increased risk of death as a result of COVID-19 infection. Oddly enough, tenofovir, as part of the antiretroviral regimen, appeared to be protective with respect to mortality from COVID-19. The precise reason for that reduced risk is not entirely elucidated, and it does match some data coming out of the Spanish cohort. It might very well be that persons who are on tenofovir, because someone who is on tenofovir has to have essentially normally functioning kidneys, their GFR or glomerular filtration rate has to be within filling node levels. That might be a proxy for this person does not have significant kidney disease and therefore is otherwise healthier than someone who might be on something like a bacavir, which might be a drug we use for somebody who has renal impairment and so forth. So it might not be necessarily something intrinsic to the drug as opposed to intrinsic to the person who's on that drug. Additionally, anybody who had a CD4 of less than 200 during COVID-19 epidemic was more than 2.3 times higher risk of mortality. The limitations to this particular cohort study were that there was no weight or BMI data. So there would be some confounding in that report. There was no hard data on socioeconomic status, even though the location was sort of used as a proxy. And relatively large numbers of patients in the study did not have recent CD4 viral load data. Remember, the cutoff for some of the analysis was between 15 to 18 months, sometimes as much as 24 months, or HbA1c, which is a marker for diabetes control. So there would still be some confounding with respect to disease activity in terms of HIV status as well as diabetes. The second study that I would like to discuss is the ISARIC WHO CCP UK study, which is essentially reporting on the 28-day risk of mortality among over 47,000 patients hospitalized in the UK across 207 centres between the first 6 months of 2020. So of the 47,000 patients that would have been included in the study, only about 122 persons with HIV, which is less than 0.26%, were infected with COVID-19, of whom about 91% were on ART. And as a group, which is in comparison to the HIV negative population, HIV positive persons who came down with COVID-19 were about almost 20 years younger. That would have a definite impact on risk of comorbidities. So there are fewer comorbidities among persons with HIV who also developed COVID-19. They were younger, as we said before. There were more males, and there were also more persons of African descent, more persons, Black persons in this study. So in terms of the risk of mortality among persons with HIV, so in terms of the unadjusted mortality, male or female, there was not much difference between the HIV positive and HIV negative population overall. But once you started looking at the under 50 mortality, there was a significantly increased risk of mortality in the under 50. And under 60 was just about statistically significant, just above the upper limit of statistical significance in terms of increased risk of mortality. And in terms of what the actual increased risk of mortality was, about 47% increased risk of mortality when adjusted for age. And if you control for other confounders, including sex, ethnicity, baseline date of enrollment, because the thinking was if someone was enrolled later in the study, we would have learned more about how to manage the disease and may have gotten a survival advantage as a result of better treatment. Comorbidities, hypoxia, and all those other issues. Among persons who were under 60 years old, the difference between the HIV negative cohort and the HIV positive cohort was almost 180% increased risk of mortality. So in terms of what the statistically significant differences were among the persons with HIV who survived versus who did not survive at the end of 28 days. So the older the person was, year on year, there was a 5% increased risk of mortality by each year. If you were HIV positive and diabetic, you had almost double the risk of mortality. And if you were obese, again, you were 2.89 times increased risk of mortality if you were also living with HIV in terms of mortality. If you were on ART, there was a 66% reduction in your mortality risk from COVID-19. But the limitation to the study is that all in all, there was a relatively small number of persons included in the study. So out of 47,000 individuals, only about 122 were persons with HIV. And also, there was no data on HIV clinical stage, whether the person ever had an AIDS diagnosis, what the CD4 count and viral load were at the time of inclusion in the study was unavailable. So finally, let's have a brief conversation about vaccine development and delivery. So according to WHO, there are 63 vaccines in clinical development right now and 173 vaccines in preclinical development. So there is quite a rich pipeline of vaccine candidates coming down with all different types of vaccine platforms. So so protein subunits, viral vectors, DNA, RNA, inactivated viruses, lots of modalities that are being developed. The Moderna and the Pfizer-BioNTech mRNA platform vaccines and the Oxford AstraZeneca viral vector platform vaccines are already being rolled out in different parts of the world. The criticism that was leveled at the Pfizer and the Moderna vaccines was that they had excluded, at least initially, persons with HIV. And then I think as a result of activist pressure as well as criticism for the scientific community, around about August of last year, they started including persons with HIV, but those persons would have had to be on medication and suppressed with a normal CD4 count. So that overall, as a study population, those two vaccines were found to be highly efficacious, but the HIV population was not reported as a separate subgroup with respect to efficacy and safety and adverse effects in that study population. So it is difficult to make any conclusions as to effectiveness among persons with HIV, especially persons with HIV that did not meet the characteristics that were included in the study. In other words, on medication, suppressed with a good CD4 count. Particularly in light of the fact that a lot of the persons who would be in greatest need of the vaccine are persons who are immunosuppressed and who might be viremic, because they, at least some of the early data might suggest, would be at greatest risk of having severe outcome and would therefore need to be considered for early vaccine access. So there are, in addition to those other vaccines, there are some vaccine candidates or vaccine products coming out of China and Russia that have different platforms, but those are being distributed most largely in their respective countries. They are awaiting WHO, another regulatory body, approval. There are some concerns with respect to some of the Sinovac and the Sinopharm with respect to activity. It does just about make the 50% efficacy threshold from WHO. But I think time will tell with respect to the long-term efficacy of those vaccine candidates. Now, what are some of the challenges moving forward with respect to the rollout of these vaccines? So one of the big issues is vaccine hesitancy. So there is a lot of misinformation and fake news and conspiracy theories with respect to the vaccines. And in some countries, for example, in France, it's just about 54% of persons either strongly agree or agree that they're going to take the vaccine when it's available. In the United States, it's just under 2/3. Whereas for example, in India, China, and South Korea, they're hitting close to 80, 90%. And that is going to have a significant impact in terms of where we want to be with respect to herd immunity, because if the persons in their respective countries just are not confident and don't feel the vaccine is safe, they're not going to take it. If they're not going to take it, we're not going to achieve herd immunity, and we're going to continue to have this rumbling transmission networks because the population will not be adequately vaccinated against it. There were also concerns with respect to the potential use of adenovirus vectors. For example, the Oxford AstraZeneca vaccine, as well as some of the other, the Johnson & Johnson vaccine, because there was, in a previous HIV vaccine trial, they had actually found that the use of a particular adenovirus as part of the vaccine platform among uncircumcised adenovirus seropositive men actually increased the risk of HIV virus acquisition. So one of the persons who were deeply involved in that HIV vaccine trial did give an editorial to Lancet expressing some concern with respect to whether or not these COVID-19 vaccine candidates that use adenoviruses might be putting persons living with HIV, who are not persons with HIV, sorry, persons who are at high risk of acquiring HIV, at risk of high risk vaccine acquisition. Sorry. as a result of the adenovirus vector, but there would have to be some very close monitoring with respect to rates of virus acquisition among those populations. And one of the other potential concerns that is now coming to light is that some of the new SARS-CoV-2 mutations might affect the effectiveness of some of the vaccines. So in summary, the relationship between HIV and COVID-19 is complex due to the biological, social, and behavioral elements that affect both conditions. Emerging data seems to confirm that uncontrolled HIV infection is a marker for worse outcomes in COVID-19, and the effectiveness of various vaccine candidates is yet to be fully established in populations living with HIV. And that's the presentation. Thank you very much.
But I wanted to ask, though, with tenofovir, because before they were saying that tenofovir basically was possibly making it safer for persons, and now they're saying that that very thing is what's making it less safe for persons.
No, so that's not entirely true. So there was, and I was sort of challenged with respect to how deep to go into it because I knew we only had 20 minutes. Mm-hmm. There was, or there is, some in vitro evidence that certain antiretrovirals, for example, lepiravir, if you were to do molecular mapping techniques using computer technology, essentially, so you would construct the structure of the receptor domains for the receptor site and see, well, maybe this chemical compound might actually bind to that receptor site. There was some evidence that those compounds might be active, right? Lepiravir being one of them, but when they actually did the in vitro assays, it was in some studies 333 times less active than against HIV, and to achieve a viral suppressive levels was not possible at standard doses. With tenofovir, there was, again, potentially based on molecular mapping, potential for activity, and there might have been some weak in vitro activity, but not anything clinically significant. And they did actually do some randomized controlled trials that did show no difference in terms of outcomes, particularly with respect to lepiravir, Calitra, and in terms of using Truvada as pre-exposure prophylaxis for SARS-CoV-2, it was not effective. What the study in Western Cape showed was that persons on tenofovir appeared to have a low risk of a severe outcome if among someone with HIV who became infected with COVID-19. The difficulty arises that whether or not that difference in severe outcome was as a result purely of the drug itself, whether or not it was an indicator that someone who is on tenofovir, a tenofovir-containing regimen, is more likely to not have chronic kidney disease, for example, because you would need to be on another drug, for example, usually a bacavir, if you have chronic kidney disease. So it might be a marker for that, as opposed to something related to direct antiviral activity against COVID-19 of tenofovir. So it would require a lot of statistical analysis, and because some of these study populations were small in terms of the absolute number of HIV positive persons included in the studies, it becomes difficult to tease that out. Because you're trying to tease out a small difference statistically using a small population. You just don't have enough data points to determine, to control for all those factors.
And then what about, do you have any information about the vaccines that are being procured or suggested for Trinidad and Tobago?
So with respect to the vaccine, so we know based on the broad studies that were done among general population, they are shown to be safe and effective, right? The issue arises that for a significant part of the enrollment for those studies, they did not include personnel with HIV. And in terms of the absolute numbers that were included later on, it's maybe a couple hundred out of 30 or 40,000. So it's not large numbers. So if there were a difference in efficacy or safety, it would be difficult to tease out, because it's almost as though you have 40,000 models and you're trying to find 2 or 3 to see if they look slightly different. If you understand where I'm coming from in terms of outcomes, you may not have enough data points to demonstrate difference in outcome, difference in effectiveness with so few data points. That being said, I believe there is no reason to suspect a differential safety signal. So right now, the intention is whatever vaccine that comes down to us, whichever one it is, because right now there are 3, and as you see, there are lots that are under development, quite over 200. So through the COVAX mechanism, whatever those vaccines are, we have to get initial access to, we will be giving the person to a person with HIV. I think the issue is how high up the priority list will be placing persons with HIV, right? Because we have those the elderly persons, and then persons who are frontline health providers, and then how far down the person with HIV go. I think in the UK it's like 3rd or 4th. I'm not sure actually WHO guidance is on that. I'll have to check.
That's great. So thank you for another great session.
No problem. Thanks so much.